little bit more in terms of who should it be done and by whom. It's two parts. The first one is this was done predominantly at 2 centers. Is that correct? So
it's true.
You might want to comment on the experience of the operators, because this data like this could be translated to a very broad experience, especially throughout our country. And the second one has to do with exactly in whom should it be done. And I'll give you 2 cases. One, both present with inferior infarcts. One patient has a proximal LAD, and the other patient may have a second OM that is, they're both positive on FFRs. Now, I can't believe that both of these patients are the same and might contribute the same in terms of your endpoints. Do you have any insights on any of these?
Yeah, if I may answer the second question first.
Sure.
I would like to put it a little bit differently, if you will allow. I think that our data support that complete revascularization can be done without harm and with a very good outcome. So you might argue, why wait for the readmission, either on the indication of stable angina or on the indication of unstable angina with the need for urgent PCI. However, if the example that you gave during the primary PCI, you needed a short stent, good diameter, with a relatively low risk of stent thrombosis in case of a non-compliance to dual antiplatelet therapy. And the additional multi-vessel PCI consists of a very complex PCI with many stents. Then I think that the lack of difference in hard endpoints might support a little bit more conservative strategy.
Yeah.
Did that answer your question?
Yes, it does. And your experience, are these all done by very experienced interventionists?
Yes, these are done by 16 PCI operators, and I think that the 2 institutions have about 1,600 primary PCIs a year, so every operator is skilled.
Dr. Sunil Rao.
Congratulations, terrific study, very important question. I was hoping to get your thoughts a little bit on the component of the primary endpoint, which is ischemia-driven revascularization, which in an unblinded trial, when half the patients have known residual disease, could potentially bias against the IRA-only arm. There's been a very nice analysis by the folks at McMaster, for example, looking at a simple difference of 2 or 3 patients in the culprit trial actually making the result neutral. So can you comment a little bit about the inclusion of the ischemia-driven revascularization endpoint in the overall composite and how that should factor into the decision-making that clinicians have?
Yes, we wanted to stress quite precisely the wording of the guidelines, which state that the repeat revascularization could be either due to subjective or objective ischemia, to answer this question. But of course, there may be a bias when the patients leave the hospital and know that they have a stenosis that are untreated. However, we also wanted to be able to translate the clinical data into clinical practice. And the repeat revascularizations are done by many other centers than the centers that do STEMI. So we want to make it up to the discretion of the physician to decide when to do the repeat revascularization. But we acknowledge that there is a risk of selection bias here.
Well, thank you, Dr. Engstroem. We're going to continue with our program then.